So it's my pleasure to introduce my colleague, Dr. Doug Opel. He's a faculty member here at the Truman Cath Center and is an assistant professor in the Department of Pediatrics at UW. He received his BS from Duke and his MD from the University of Chicago Pritzker School of Medicine and completed his pediatric residency here and served as chief pediatric resident in 2006. He currently practices inpatient general pediatrics here at Seattle Children's, and his research focuses on provider-parent communication, health communication, public health ethics, and clinical ethics consultation. And he's going to be talking about physician, patient, parent, where exactly is the line? Doug?
Thank you, Holly. So I apologize for not having slides in your booklets, and the reason for that is really because what I'd like to do in the next 20 or 30 minutes or so is get personal and tell you a story about myself. So I have very few slides, and as I go through the 5 or 6 I have, you'll understand why they're not in your book. But before I begin, let me first say that historically, getting personal is not something I'm accustomed to doing. I'm a reserved, keep things close to my chest kind of person when it comes to my personal life. Proof positive of this, I've yet to join Twitter or Facebook. Mithya, you're not the only one. In fact, 140 character updates on what I'm doing whenever I'm doing it sort of makes me want to vomit. Dr. Swanson, I'm ashamed. But in some ways, that is the old me. To show you how far I've come, let me begin this talk with something really quite personal. Pictures of my small intestine. I show you my insides, yes, to get personal, but also because my small intestine plays a not so small role in this talk. And as you'll see, it's a role that embraces both anguish and appreciation. I have Crohn's disease. This talk is about how my experiences with this disease have shaped my perceptions of boundaries in medicine, particularly around the issue of self-disclosure. I became a pediatrician first, then a parent, and now a patient. And with each new role, I have become increasingly confused on where boundaries regarding self-disclosures in medicine lay. In this talk, I'd like to make the case for more of a reframing and a blurring of personal and professional boundaries regarding self-disclosure. So it was only a few years ago that I was diagnosed with Crohn's. As I imagine it does for anyone who receives this diagnosis, hearing the words, "you have Crohn's," had physical, psychological, and emotional repercussions for me. And these repercussions themselves were perhaps unusual, since I was already familiar with Crohn's, learning about it in medical school and then as a pediatrician taking care of kids with it occasionally. When I was a pediatric resident, I remember one particular call night where I spent its entirety, 12 hours or so, altering a child's pain medications, dosages, and schedules, all in an effort to lessen his horrible, cramping, and unremitting abdominal pain due to Crohn's. I remember the abdominal pain winning. I also remember admitting patients multiple times over the course of a month for flares of their Crohn's, amazed at the relentlessness of the disease and the disappointing treatments we had at our disposal to put it into remission. Most of the medications we used and still use had side effect profiles that were almost as bad as the symptoms they were intending to treat. Partly as a result of these experiences, I had come to perceive Crohn's as a dark disease. I saw the emptiness, the despair, the misery left in the wake of those it affected. My patients couldn't eat, they couldn't go to school, they couldn't be kids. I considered Crohn's to be among the worst ever diseases I could imagine someone enduring, and now I had it. After the anesthesia wore off from my diagnostic colonoscopy, I was shown these pictures. For those of you who aren't familiar with what a normal small intestine looks like, here's a comparison. My intestine was inflamed, ulcerated, and bleeding. When I heard the news, my first thoughts were about having the very disease I had long dreaded. The despair I perceived my patients experiencing suddenly became my despair. I felt immediately vulnerable and remember feeling panicked about my livelihood. This is a game changer, I said to myself. I thought about quitting my career and easing out of the stress of work that surely was contributing to my disease. I thought about colostomies, drug side effects, enema preps for the now inevitable annual colonoscopies I was about to endure. From my PACU bed, I looked over at my wife, who was holding our 6-month-old daughter. My wife is also a doctor, and it took only one glance from her to know that she was thinking the same things too. It didn't take long for my health to go from bad to worse. I was anemic, underweight, and nutritionally deficient when I was diagnosed, but my pain symptoms were mild. My gastroenterologist started me on an entry-level oral medication for Crohn's intended for patients with mild disease. It didn't work. He tried me on another oral medication to try and control my GI symptoms, but that didn't work either. As I went on and off different medications intended to control my symptoms, new symptoms seemed to develop. The worst new symptom was the abdominal pain. I remember when it first hit. My mother-in-law was in town. My mother-in-law's presence was a good thing. It meant that my wife could take me to the emergency room without having to wake our daughter from her nap and drag her along. Grandma would take care of her while we were gone. I remember feeling relieved that my daughter was sleeping when the pain hit. I didn't ever want her to see me like that, vulnerable, hurting, fearful. The pain I was feeling was like nothing I'd ever felt before. It caused me to scream at its worst and whimper in anticipation for the next wave. I writhed. My medical mind forced me to visualize what could be happening to my intestines to cause this much pain. The only conclusion I could come up with was that this pain had to be due to some intestinal obstruction or perforation. I couldn't imagine that anything as excruciating as this could be due to anything less than a catastrophic gastrointestinal event requiring surgery. The nurse in the emergency room who gave me morphine was quite possibly the greatest person on the planet at that moment, second only to my wife. The pain relief she provided was akin to a spiritual phenomenon. And I remember imagining her in between pain episodes, opioids, surrealism, as this saint-like woman fitted with a glowing halo above her head reserved only for the most angelic. I also gratuitously thanked her every time she attended to me. In my mind, she was a miracle worker. Her providing pain relief was routine, medically indicated, and a simple act of compassion, but it carried considerably more weight to me since I thought I was dying. I was both grateful and completely dependent on her and the other providers in the emergency room. Well, it turned out that I didn't have a bowel obstruction or perforation. Rather, my pain was just due to the ordinary intestinal inflammation consistent with a Crohn's flare. Really, I said to the ER doctor, just a flare? I had him show me my x-ray because that just didn't compute. The pain I had experienced still only equated with the need for emergent life-sustaining surgery. I felt embarrassed. Man, I'm a wuss, I thought. Norm Faust, who was here and was part of a group of bioethicists brought together to discuss cancer and ethics from a personal perspective, and that was documented in the Hastings Center report article last year by Rebecca Dresser. He commented that there is, quote, a regression that occurs when you're a patient, no matter how intellectual or aggressive you are personally. I had just experienced this regression. I had needed some serious pampering to get me through my experience from my wife, from my nurse. Once through it, I also realized that this kind of pain was exactly what my own patients with Crohn's had to deal with. And yet, they had seemed so much more graceful and tolerant than I had been. I had a lot to learn about empathy. My foray into patienthood was only beginning. A few weeks after I left the emergency room, I had an appointment with my gastroenterologist who wanted to discuss the next steps in my treatment. The current strategy of oral medications for my Crohn's was clearly not working, and given my recent flare, he told me my Crohn's was probably now better classified as moderate to severe rather than mild. The current approach to treating moderate to severe Crohn's, he told me, was a top-down one. The drugs usually reserved as last options for patients with mild disease were first options for patients with moderate to severe disease. He recommended that we take this approach and start with a drug given intravenously. This would mean I'd have to come into the hospital to get the infusion, which would last about 4 hours. At first, I could get these infusions every 8 weeks, but depending on my response, I might have to do it more frequently and at higher doses. It was likely to be effective, he said, but it was also more likely to include side effects, and bad ones at that. A certain, albeit small, proportion of patients on this drug develop cancer. To top it off, it was expensive, $10,000 for each infusion or thereabouts. And because resistance routinely develops if one stops taking the drug, I'd likely need to remain on it indefinitely. I left the appointment completely uncertain about what to do. I was in no way ready to accept the burden of being on a drug given intravenously every 8 weeks for the rest of my life. Yet, I was also in no way willing to be at the mercy of another flare like the one I had just been through. I decided to look things up in the medical literature like I would for any difficult clinical scenario I was in as a physician. I searched PubMed, original research articles, ongoing clinical trials. Frankly, this might have made things worse. I found the evidence confusing and difficult to sort through, and while I could understand the medical information in front of me in a generic sense, I couldn't figure out what it meant for me. My wife and I couldn't figure out what it meant for our family. How was I supposed to match my values and my goals with the information I was reading and each option available? I called upon a few pediatric gastroenterology colleagues for their advice, hoping they'd just tell me what to do. They didn't. They reiterated the options and left me to decide for myself. I didn't want to make this decision. Despite looking at it from every angle, I couldn't think it through decisively. I felt totally dependent on others. I made another appointment with my gastroenterologist to discuss the options again, and he listened to me, my uncertainty, and clarified some questions I had. And again, he strongly recommended the IV drug called Remicade. I decided to agree. Leon Cass, who was also part of this bioethics group discussing cancer from a personal perspective, summed up nicely what treatment decision-making feels like. Quote, "You look at this side, you look at that side, and you hold your nose and leap." And leap or not, I had developed a profound appreciation of the complexities and psychology of patient decision-making. All the while, enduring these transformative patient experiences, I was busy being a doctor. Whether I wanted to or not, I practiced medicine differently because of these experiences. I internalized the dependence, the loss of control, the vulnerability I had felt, the difficulty with making a treatment decision, and the obscurity of matching my values with my decisions. These fundamentally changed me as a person and consequently as a doctor, and I think for the better. I certainly felt enhanced with these new insights and appreciation of the patient experience. Dr. Opel 2.0, I called myself. The natural next step for me seemed to be to figure out how I could maximize these benefits. I decided I was going to disclose my illness and own patient experience to patients of mine who are going through the same thing. I got my first chance to do this not long after starting Remicade. I was attending on the wards and admitted an adolescent who had symptoms concerning for an inflammatory bowel disease. We ultimately diagnosed her with Crohn's. Aha, I said to myself, something I know a bit about and can relate to. I can tell her about what to expect, tell her what I've been through. I can say, I know how you feel, and truly mean it. In the end, though, I balked. I entered and left my relationship with this patient like all others before her. I didn't disclose anything about my experience with Crohn's, nothing about my emergency room visit, my abdominal pain, my uncertainty, my vulnerability. Instead, I stayed firmly and comfortably within my traditional role as her doctor. When push came to shove, I felt uncomfortable getting too personal and worried that my intentions would be misinterpreted. I worried that self-disclosing my own illness was crossing a boundary. This bothered me, and it helped me realize that now that I was both a doctor and a patient, the current established boundaries in the doctor-patient relationship make less sense, or at least how we talk about these boundaries make less sense. It seems that most boundary discussions begin with the assumption, implicit or explicit, that we ought to keep the professional and personal separate, and let's work back from there. Supporting this starting point are arguments like we've heard today that we need to maintain objectivity, not undermine patient trust, and not risk patient harm by entering into more personal relationships with them. Fine, that makes sense to me, but what are we missing by starting from this point of separation? Physician self-disclosure perhaps offers a good case study. Although historically thought of as a way to strengthen the physician-patient relationship and therefore generally encouraged, physician self-disclosure has recently become more controversial, and boundary discussions that include it seem to increasingly begin from the starting point of separation. Probably shouldn't do it. Here's a recent study by Susan McDaniel and others at the University of Rochester that supports the starting point of separation. Its title, as you can read, is Physician Self-Disclosure in Primary Care Visits. Enough about you, what about me? They found physicians commonly self-disclose information about themselves to patients in first-time visits. Some of it seemed non sequitur, some of it disruptive. None of it seemed to have a positive patient effect. Here's an example. Patient, I'm 6 feet and she just told me I was 204. Physician, is that up a little bit for you weight-wise? Patient, it might be up a few pounds. I used to jog and I just haven't. Physician, see, because I'm weighing more like 172, 173, and I'm 6 foot, and I'm still running. I'm still doing the 5 and 10 and 15 Ks, the half marathons, and patient, so I'm 30 pounds heavier than you? Physician, right now, yeah. They concluded, probably rightly, that physicians should think twice about self-disclosure, or at least be careful about when, how, and why you do it. And while I suppose this is an appropriate conclusion, especially when physician self-disclosure inadvertently creates competition with your patients, I wonder if they got the framing wrong. I wonder because buried within this paper, I discovered that the authors found 3 examples of physician self-disclosure that were useful and had a positive patient effect. In all 3, the self-disclosure involved the physician mentioning that he or she had the same medical condition as the patient. Here's an example of one. Physician, I suffer from it myself. Patient, oh, you're kidding me. Physician, absolutely. Patient, so what I'm saying to you is what you have, the exact same thing? Physician, exactly. Patient, oh my gosh. Physician, exactly. Patient, what a coincidence. Physician, basically the acids are in the stomach are coming back up. That's the reflux, and that really irritates the lining of the esophagus. I would have liked to see the title of this paper be something like The Positive Patient Effect of Physician Self-Disclosure of Illness. Yes, I get that we should worry about all the other types of self-disclosure the authors heard doctors using, but let's not have that be the focus. Let's focus on the kind of self-disclosure that worked, in which the doctor drew upon his or her experiences as a patient in order to educate, support, explain, or acknowledge the patient's experience. I think we too often get bogged down in how to protect doctors and clinicians from themselves instead of nourishing a culture that promotes a healthy doctor-patient relationship. This is what it feels like we are doing when we emphasize what we should avoid regarding self-disclosure instead of what has a positive patient effect. This very starting point seems to diminish, disregard, and downplay the incredible insight we can gain in one role from the experiences we have in another, and seems to hinder, dissuade, and suppress our ability to take advantage of those insights to improve ourselves. So let's turn things around. Maybe shared experience of illness and the ability of self-disclosure to nurture that shared experience should be the rule, not the exception. Many, if not all, of us are patients ourselves, so why not capitalize on this shared experience that we have with our patients? It offers an incredible potential opportunity to deepen our therapeutic relationship with our patients, to build trust, to deepen understanding, maybe even improve patient outcomes. It seems we could start with the assumption that self-disclosure of our patient experiences is beneficial and we should self-disclose them explicitly. And then let's work back from there. Doing so will inevitably uncover that we shouldn't self-disclose indiscriminately or gratuitously without tact or with an intent other than to build trust, rapport, and ultimately to benefit the patient, but by beginning from a starting point of doing rather than avoiding, those issues are less likely to distract us away from the overall good that self-disclosure can bring to the doctor-patient relationship. It will also allow us to raise and discuss some provocative questions and maybe even test some of them empirically. Does disclosure by clinicians of certain illnesses have greater positive effects on patients than other illnesses? Is the ability of self-disclosure of illness to improve the doctor-patient relationship dependent on the type, severity, or chronicity of the illness disclosed? Why limit self-disclosure of illness to only those circumstances where the clinician suffers from the same disease as the patient? Why not be transparent about a different illness that we are suffering from that is relevant in some other way to what the patient is going through? Won't we see the same positive patient effects of support and acknowledgement by doing so? My take is that self-disclosure of illness should be interpreted broadly. It doesn't have to be confined to, I have Crohn's too. Recently, I talked to a worried parent of a 2-month-old patient of mine who was considering delaying several immunizations for her child. And I told her I understand her anxiety because I was anxious too when my kids were due for their first shots. She was shocked that I could have been conflicted at all, but it was also very normalizing for her and helped her decision making. I talked to an adolescent patient in my clinic who had asked me about improving her compliance with her taking her daily inhaler. I told her that I get how it feels to have to face taking a daily medication, maybe for the rest of your life, because I have to take medications like that too. An 18-year-old patient of mine with newly diagnosed diabetes expressed to me his devastation at the thought that his disease will likely cripple his career aspirations. I told him, hey, I've got a chronic disease too, and I'm not letting it stop my career. We can tailor our personal medical experiences to match those of our patients, extracting those tidbits that are likely to be the most applicable and supportive. I think there are positive and transformative outcomes that await us and our patients if we do. It doesn't take much to realize that this is what pediatrician parents do all the time. I have 2 kids, and as any pediatrician parent will tell you, there's little you learn in medical school and pediatric residency that prepares you for parenthood. But the reverse, I think, is very true. I'm a better, or perhaps better put, a more informed pediatrician now than I was before I had kids. I understand what it takes to raise a child, make decisions on behalf of my child in a healthcare situation or otherwise, and what it's like when they are sick. And I tell the parents of my patients this. I tell them I'm a parent myself. When they raise a health or parenting issue that they are dealing with regarding their kids, I tell them about a similar experience I had with my kids, like I did with the parent who had immunization concerns. This shared experience, much like that of being a patient, is invaluable to my relationships with parents. It's my perception that pediatricians are more likely to feel comfortable talking about their own kids with parents of their child patients than they are talking about their experiences dealing with an acute or chronic illness. Certainly, we all have varying comfort levels with disclosing information about our personal lives, our kids, or our illnesses. And in no way do I think there is an obligation to disclose either. But I want to encourage us to be more open to doing so. The other day I came home from one of my Remicade infusions, and my daughter, now 4, noticed a bandage on my arm where my IV had been. Instead of explaining it away like I had been for the previous 4 years as an owie I got at work, but it's all better now, I decided to tell her what actually had happened. Daddy is sick, I said, and this is where I get medicine to help me get better. Now, she had a lot of clarifying questions. But then she just sat calmly on my lap and met my eyes with hers. Fully expecting her to begin with a second round of questions after just having processed the first round of answers, I instead got a big surprise. She said, "I love you, Daddy," and she gave me a big hug. Thank you.